Hello, my name is Jasmine Aulak, and I'm a fifth-year psychiatry resident who, alongside with my colleague, Dr. Arnold Lee, and under the supervision of Dr. Kamini Vasudev, have been working on a quality improvement study. We evaluated the assessment and intervention in mild to moderate major depressive disorder in our adult mental health services compared to Health Quality Ontario standards. Today, we'll be presenting our initial results. So the Health Quality Ontario created 12 quality statements or standards to guide the provision of high quality evidence-based care for adults and adolescents with unipolar depression. We completed a retrospective audit of 185 eligible charts of adult patients aged 18 to 65 years old who were assessed between September and November of 2018 and diagnosed with major depressive disorder or persistent depressive disorder. They were seen through urgent care or through the general adult ambulatory mental health service. We looked from the time of initial referral to 6 months follow-up and focused on the first 6 Health Quality Ontario quality statements. Statement number 1 outlines elements of a comprehensive assessment, which should be available in a timely manner. In the interest of time, I will only highlight the most significant disparities as compared to the Health Quality Ontario standards. As you can see, the average time between date of referral and date of assessment was almost 32 days, with a wide standard deviation of 28 days. Health Quality Ontario specifies that the timely access for mild to moderate depression is within 4 weeks. DSM-5 criteria for diagnosis of depression was only used in 82% of cases, and almost a third of consultation reports did not specify screening for bipolar or psychosis. Relevant details regarding medication or psychotherapeutic interventions used in the past were documented in only between 35 to 45% of cases. Relevant screening investigations were only completed in 13% of cases, as you can see here, and symptom severity scales were only used in 3% of cases. Quality statement number 2 specifies suicide risk assessment and intervention. There were no documented use of suicide risk scales. About 84% of the elements of the suicide risk assessment from history were completed on average. There was minimal preventative intervention as indicated here. Quality statement number 3 identifies the need for shared decision-making. There was no documented use of any decision aid tools. Medication options were discussed more often than psychotherapy, but with low rates of documented discussions around medication side effects, risks, or costs. And this is an example of a patient decision aid tool for the use of antidepressants. Quality statement number 4 specifies timely access to antidepressant pharmacotherapy or evidence-based psychotherapy, and the standards highlight cognitive behavioral therapy and interpersonal therapy specifically. In our data collection, medications were offered in almost 84% of cases, most commonly either starting a new medication or adjusting their current medication dosing, and psychotherapy was offered in almost 70% of cases. This was most commonly cognitive behavioral therapy or CBT, but that was only in about a third of cases. Quality statement number 5 outlines the use of adjunctive therapies and self-management. This was a significant area of discrepancy. These interventions were provided minimally in any form in only about 13% of cases. Quality statement number 6 specifies that initial follow-up should be at least every 2 weeks from initial consultation for a 6-week period with regular monitoring of suicidal thinking and treatment adherence. No follow-up was documented in 35% of cases, and about 47% of cases did have scheduled follow-up. On average, this was 54 days later, plus or minus 28 days. There were on average 1.12 follow-ups provided, about 41 days apart. Only 21% of follow-ups commented on treatment adherence, and less than 30% documented a suicide risk assessment. Overall, our quality improvement data collection indicates that there are several areas for quality improvement intervention. We look forward to replicating this audit following changes. And much thanks to Dr. Vasudev for her supervision in this research project. Thank you.